Egypt. It's my honor and a pleasure being invited to moderate.
Sorry to interrupt you, Rasha. We've just gone live, so you can do your introduction now.
Okay. Hello, everybody. This is Rasha Shmeis. I'm a nephrologist from Egypt. It's my honor and a pleasure being invited to moderate this valuable webinar. Thanks, Yannick, for the kind invitation. And thank you once again for taking this initiative of Share Your Article. Share Your Article is a new webinar series organized by the Young Nephrologist Committee. And the invitation is inclusive for everyone interested. You can send an email and share your article via the email address that will appear in the chat box. It's my deep honor and pleasure to welcome our dear guest, Dr. Valerie Lakes. Dr. Valerie, she's a truly remarkable person who has made a profound impact on nephrology in Africa. She's not only a mentor and expert, but also source of inspiration, guidance, and kindness. I personally and deeply owe her a lot. And with all my heart, thank you, Valerie, for all what you're doing. It's now time, and my pleasure to present Dr. Tofi Dennis George. He's a nephrologist trained in Cameroon, Morocco, and Holland. He's a pioneer lecturer in nephrology and internal medicine. He works in the Faculty of Health of Science in the University of Pune, and he's contributed to advanced nephrology in Cameroon and medicine. Dr. George, congratulations for your published article, Quality of Life and Social Reinsertion of Patients on Maintenance Hemodialysis in 4 government-funded hospitals in Cameroon. Please go ahead and present your article. We are all ears. Dr. George, you're unmuted.
Can you get me?
Yeah.
Okay. It's a real pleasure to be part of this panel. I would like to thank the organizing committee who have selected our papers to be the topic of the discussion today. Also, thank you for the warm introduction. We thank Valerie to have accepted to be part of us today. And the paper I'm about to present, Quality of Life and Social Reinsertion of Patients on Maintenance Hemodialysis in 4 government-funded hospitals in Cameroon, is a paper that is issued from a work that we initiated as a MD thesis. So it's a MD thesis, and the research team was composed by Mervis Shebing, who was by then the medical student. We have the Professor Marie Patrice Halle, we have Professor Gloria Ashutantan, Professor Emin Fuda, and myself were acting as a co-supervisor of the work. So to go through the paper and the work, I think we'll follow this outline. After a brief introduction, we'll tell you about our objectives. We'll explain our materials and methods and our results before we conclude. We should well understand where is the place of the kidney failure actually in the world as a major public health problem. The number of people with chronic kidney disease keep on increasing, as well as the burden in the system, the burden in the patient, the burden in the health worker, as we can estimate that over 2 million people are receiving dialysis worldwide. The situation in sub-Saharan Africa is also alarming, where we can count 9% of those 2 million undergoing form of dialysis, hemodialysis being the most common, and in some parts of sub-Saharan Africa being the only both of renal replacement therapy. We are reminding here that hemodialysis is some sort of palliative treatment which is time extensive and very expensive. And it affects the patient in many ways. It can affect the physical and the psychological health of the patient, and most of the time, the social aspect of life, that social aspect of life that we tend to neglect in our daily practice. So the patient on maintenance hemodialysis will face a lot of difficulties. Difficulties continuing normal education, difficulties getting a job, difficulty maintaining the social activities, and the quality of life is always compromised, and what explains the poor social reinsertion. The concept of health-related quality of life was defined by CDC as the individual perception of the effect of a medical condition or its treatment in the physical and psychological well-being of the patient. It is a well-known, actually, predictor of mortality and mortality in patients with kidney failure, and slowing deterioration of the quality of life or improving that quality of life is a key management of kidney failure, actually. When we look at this, we see before dialysis, we all agree the quality of life of the patient usually decrease. The patient is inactive, the patient has symptoms, and after initiation of dialysis, there is some degree of regain of the quality of life. So it's worth evaluating what happened in our patient around. And in this other slide, we see that even in countries where what we call developed country, we see that many patients undergoing hemodialysis are not employed. We can see up to 78% in America, which are not employed due to their situation of or their status of hemodialysis patient. So what is the problem? In our community, we have little data that talks about quality of life and social reinsertion in patients we are admitting in dialysis. And we can acknowledge that the number in the dialysis, in hemodialysis in Africa and in Cameroon is increasing. So we need to know what is the problem, what is happening. So the objective of this was to assess the quality of life and the level of social reinsertion of patients on maintenance hemodialysis in Cameroon. And specifically, we wanted to assess the quality of life, evaluate the level of social reinsertion, determine the factor associated with the quality of life, and then evaluate the association of the quality of life and social reinsertion in that population. We went for a cross-sectional descriptive and analytic study carried out in the year 2002, and we visited 4 hemodialysis units in Cameroon. The 4 had in common the fact that they are all government funded. They offer 2 weekly sessions of dialysis of 4 hours, and we can say the 4 centers represent more than half of the dialysis population of Cameroon, because in this we have the most frequent center in Yaoundé, Douala, and we are being the most center in region. So we took that. The sampling we used was a convenient and consecutive sampling. We tend to see all patients receiving hemodialysis in the 4 selected hospitals. So we excluded patients with cognitive dysfunction, eventually people with stroke and non-controlled heart failure. Our aim was to see as much as possible patients on maintenance hemodialysis. For ethical consideration, we had the clearance from the Institutional Review Board of the Faculty of Health Science of Boya, and each patient were explained the objective of the study and were asked to sign a consent. We had a consent from all participating patients. We use the KDQL 36 to evaluate the quality of life. That is, we had the physical and the mental composite and the effect, the symptoms, and the burden of kidney disease on the patient. Then a locally made structural questionnaire was established to evaluate education, employment, relationship, and social participation. Data were entered in the SPSS, and we use a chi-square test to evaluate for association, and multivariate analysis help us to determine some predictors. For this study, maintenance hemodialysis was defined as somebody receiving dialysis for more than 3 months for kidney failure. We decided that poor quality of life would be considered as a score less than 50, and the poor social reinsertion was considered as major adverse change, like dropping from school, like being not going for work, not having employment, not having suitors, or divorce. Those were the social reinsertion element that we discussed. What did we have as a result? We went through 500, we approached 502 patients, and finally 434 agreed to be part of the study, in which the mean age, the population was relatively young, with a mean age of 48 years. 2/3 of the population were male, as the distribution in the society. We had a good number that were married, and the dialysis vintage was 3.74 years. We had 76% of patients who had less than 5 years in dialysis. When we look at the causes of chronic kidney disease in those patients, as usual, hypertension, diabetes, and chronic glomerulonephritis were the most common situation associated to the chronic kidney disease. And evaluating, we had 74% of patients whom the quality of life was estimated to be good. When we look at it in details, we saw that all the 5 subscale of quality of life show a good representation, except for the burden of the disease and the effect on the disease. That is the perception of the patient. When we look at the academic reinsertion, we see here that when it goes to education, we see that 67% of our patients drop out from school. 67% drop out from school. And among those who continue school, the 24 that continue school, only 6 were able to obtain certificates. 18 were able to complete the level. So we see that there's no good achievement when it comes to academic. And when we look at the reasons why they were absent from school, we see that fatigue is one of the most element that was reported. But we should not neglect some patients reported that reported depression as the reason of dropping or not improving in school. When we look at unemployment, we see that the reasons why patients think that they are not employed is that they say physically they are not fit to work. Physically, they are not fit to work. That is for the majority. Almost half of the patients said physically they were not. But we see that a good percentage had their job terminated because they were admitted in dialysis. Same, we have some who were not able to see employment after initiation of dialysis, and 3% of patients drop voluntarily from their employment, maybe because of fatigue or other symptoms related to dialysis. When we look at suitors, we see that almost all patients said no suitors since they have been on dialysis. That's 83%. And some had, after the dialysis, they say that some of their relatives were pushed away. That is, some of those who were in relationship, those who were married, some people were pushed away. When we look at the perception, this is the patient perception on the impact of dialysis on social reinsertion. We see that on education, the perception was poor, either for education, employment, social participation, and relationship. Were poor that. And the factor associated, when we look at the factor associated, we try to analyze what factor could be associated on multivariable analysis. The only factor that we had here was the age, and people aged 22 to 65 showed to be more affected with that, and we can understand 22 to 65 is the most active age. So when they are admitted in dialysis, they feel like they feel it more in their psychology than any other group of patients. We had no difference concerning the gender. When we look at other correlation, we saw that the social participation is what influenced the patient who succeeded to keep some social participation had a good health-related quality of life. Now, what can we conclude? We can conclude from this that patient on hemodialysis has the quality of life of patient on dialysis is low. More patients are burdened by their disease, and the physical health status is more affected. Older patients, when we say older here, we keep on thinking about the 22 to 65, have shown to be an independent determinant of poor quality of life. When we go to social reinsertion, we can say the social reinsertion of those patients were poor, with 7 out of 10 that dropped of school, and almost half of our participants were unemployed. On the patient that we interview, no marriage, no promotion or employment occur during their stay in dialysis, and we note that 2 patients, we had 2 in that divorce. We have 2/3 of the patients that were socially excluded, and the poor quality of life was directly associated with poor social participation. This study had some limitation, like any study based on screening tool. We had the reporting bias. This patient may not have given us their real situation, but it's what here bringing out the strength of this study, because compared to what we saw already published, we had a pretty large sample size, and we tried to go around to make it represent what is the situation in Cameroon, and by then we can extend it to sub-Saharan Africa. So some recommendation that we will make after this to the government, we thought that the government could make education free in public, especially for young people and those on dialysis. We could even think of bringing the school to the dialysis unit rather than allowing them to go to there, and even try to manage their time so that they can be able to continue their school. For the hospital administration, we thought it wise they can include psychologists to the dialysis team to provide psychological support, and social worker should be around the dialysis team. And to the nephrologist, we advise that we should always evaluate the quality of life. We should not be centered on the quality of dialysis. We should also evaluate the quality of life, because that's what matters most of the time for those patients. So with this, these are some elements we had to share in our articles, and I will still thank those who read so that their participation may help to not improve the paper since it's already published, maybe improving our next ideas in people with on hemodialysis. So Rasha, this is my presentation.
Thank you so much. Thank you so much, George. And congratulations once again to you and your team for this elegant work. Indeed, it's a very interesting study, and it's interesting to know about the dialysis in Cameroon. And as you mentioned in your article, from around 2 million people undergoing dialysis all over the world, only 4,000 are doing dialysis in sub-Saharan Africa. It's interesting to know more about the situation of hemodialysis in Cameroon. Are all centers are government funded? Um, how many patients are there undergoing dialysis in Cameroon?
Actually, undergoing dialysis in Cameroon, we can count about 1,000 patients undergoing dialysis in Cameroon.
Yeah. And are all centers are government funded?
Yes, many centers in Cameroon, we have the government is the main initiator and founder of center. We offer dialysis in Cameroon. We have some private centers, but in terms of number, they are not really representative. And many of the centers, private center, they do only acute dialysis. They don't do dialysis for chronic patients.
Yeah. As you mentioned, George, in this study that the centers included offers twice weekly sessions for hemodialysis patients. Is this a situation for all centers in Cameroon? Do they all offer twice weekly sessions for dialysis?
Yes, I think the government dialysis policy in Cameroon is that we give 2 sessions per week. So all the government-funded centers, they give 2 sessions per week in Cameroon.
Yeah. So we have a comment and a question. Congratulations to you and your team on this very informative paper. Here is the question: how you excluded patients with heart failure based solely on medical history or in the performance of cardiac ultrasound, since we know the high prevalence of heart failure in hemodialysis patients.
We, in the exclusion criteria, we did not exclude all patients with heart failure. We said we excluded patients who had non-controlled heart failure, the patients who were still symptomatic. Those ones, we excluded them. But patients with heart failure with a good treatment and control, they took part to the analysis for the study. So only those who were not controlled and still very symptomatic will not be evaluated for the symptoms. So we excluded them.
Yeah. We encourage everyone to share their comments or questions via the chat box. And I'd like to ask you, George, what inspired you to conduct this study on the quality of life for patients undergoing dialysis in Cameroon? And what do you think are the many challenges patients on hemodialysis are facing in Cameroon in particular?
I think this study was in line with a number of studies we have conducted in patients on hemodialysis, because in the previous years we were focused on controlling their blood pressure, controlling the hemoglobin, controlling their glycemia, those main elements that we thought was the main challenge in dialysis, making them having a good quality of dialysis. But we forgot that there are some aspects that we need to really investigate and know if we are doing good in that. We take people on dialysis so that they can be able to have a good quality of life. They can be able to go back to the society and produce and help the society with their know-how. So it was important for us to evaluate that aspect of dialysis. What is the situation? What can we do to improve that? When you have young children who come for the dialysis, because more and more we have children on dialysis, we should know about their education profile. We should look at what we can do to improve that. So those are some few elements that inspire us to go for this.
Okay, George, there is another comment. It was not possible to obtain certain information on the quality of dialysis that could have an impact on your score, such as a KT/V or residual kidney function, and so.
Yes, I totally agree. Those are those are elements that are known to influence the quality of dialysis. We are giving 8 hours dialysis per week. So all our patients, who put it in quote, may have some complication related to poor, I'll put poor in quote, poor dialysis. But in that situation, we still need to know what we are sending out to the community.
And you routinely do the assessment for adequacy of dialysis using the KT/V or other measures?
Yes, we do. We do.
Yeah, that's great.
But in this study, we did not. It was not an objective for us in this study to know if the KT or V was adequate or not. But we understand that we do that for other reasons.
Yeah, that's great. I'm particularly interested to know, George, regarding your schedule twice weekly dialysis sessions. If you have a pregnant woman, do they receive the same schedule, only 2 sessions per week, or do you have more intensified dialysis protocols?
No, when we said the policy is that we give 2 dialysis sessions per week, no, most of the time we even tend to. That's a general measure of the government. That's a general idea the government give us. But you have to identify their patient with other that would dialyze 3 times a week. If we have a pregnant lady, we know that we have to increase the dialysis dose. So it's left to the nephrologist to decide that this patient need more than the 2 sessions that is required. So our hands are not laid for that. We have that possibility to change the protocol according to what we are targeting.
Yeah. We have a question from Dr. Nono Cameroon. Does the level of unemployment in your patients different from that in the general population? Unemployment.
Yes, in the absence of, we don't have real data on the unemployment in the general population. But here I would say yes, the level of unemployment here is much more greater than what we have in the general population. When we are talking here, we are talking about unemployment here. We don't just focus on standard employment. So here we have people who have a formal employment. We have people who are in the informal traders, and so I think if we look at it that way, we see that the level of unemployment among people on hemodialysis is far greater than what we have in the general population.
Yeah. So I think we have no more questions. So I'd like to ask you, how do you think the finding of your study is gonna change or impact the policies in Cameroon as regard the dialysis? Or maybe you're going to take a personal or let's say a local policies for improving the quality of life for your patients?
Okay, I think if we need to advocate, we need to have data. We need to have study like this that tells the government, that tells the decision makers that this is a problem, and this paper have identified a problem or many problems. So we can use this to advocate now for, as I was saying, these children that drop out of school. Maybe the situation is the 2-session dialysis for the children are not enough. Maybe is that the school where they go is too far from the dialysis center. That's what I was talking about, bringing school to the dialysis center rather than taking the children out of the dialysis center to school. Maybe the stigmatization that they have in school will make them to drop to school. So I think it's a group of people that we need to think on how to improve in their education, in the education, how to make their education more available to them. We should not just put them as the general population. Then when we look at employment, we have seen that many of the patients drop out from their job for many reasons. Maybe they were not longer efficient and the administration found that they cannot continue, or the patient itself decided to. So with the results of the paper, we can still go out and tell those who are responsible of giving them job and everything that a dialysis patient, when the patient is well dialyzed or when the patient does not have a major complication, can still work and produce and have and produce sometime, maybe not more, maybe just as somebody who does not have kidney failure or who is not on hemodialysis. So we needed the data. Now, if we want to advocate for any of these, we'll have elements to back up.
Yeah, but before this, we have a comment from Dr. Abdelali. I think the quality of life evaluation must be in first line before KTVRV. So what is the best survey or questionnaire evaluation you recommend for that?
I think the short form quality, dialysis related quality of life is what has been used in many other studies, and it has shown that it gives reliable results. But we can go also on the general, because this one is specific to kidney disease, but we can also use the general, the WHO form for evaluation of quality of life in this group of patients. That will also help us to come out with some other elements that the dialysis related quality of life may not give us.
Okay. There is a comment for you, George. Thank you, doctor, for your presentation. Given the relative scarcity of mental health experts in the country, is any form of psychological support currently provided to patients on hemodialysis?
Actually, I will talk for the few centers that I've visited or where I've worked. We don't have provision for psychologists in the hospital. So in the dialysis center, sometimes the nephrologist, you do the nephrology and you also do that part of psychology. And we can really understand that it's limited because the nephrologist, you have many other things to do. You may not have the adequate time to even just listen to the patient, not even talking about bringing solutions. So we don't have that provision, and we think that's something that, if available, it may help the patient to overcome some of these challenges.
Yeah. We have a comment from James Tatao. He's congratulating you and your team. Just a question and remark. Will the universal health coverage now instituted in Cameroon be a good step toward addressing all other social determinants of improved care for dialysis patients?
Yes, thank you, James. I think with the coming of the universal health coverage, is going to solve a lot of problems, including that of, because in our study, we did not evaluate the quality of dialysis, as some people said. And we know by then patients were still paying out of pocket some money to have their dialysis done. So we may have a lot of patients not adherent to the treatment, and that may impact the quality of life and what we study. So we agree here that with the coming of the universal health coverage, things are going to change. So probably we may have to do another study to evaluate what has changed with the come of the universal health coverage.
There is another comment from Sianda. There is a scarcity of studies which explore the high quality of life using both qualitative and quantitative approaches in one pot. So a qualitative approach, what do you think of this, George?
I think she's totally right. She's totally right. Quality approach may give also good results, but we can associate a quantity to, yes, it's something that can be done. It's something that can be done. And I think the results will be more comprehensive. The result will be more approach to the reality than doing just a qualitative study. So she's totally right. I agree with her.
I thank you. I think these are all the questions in the comments we have. Thank you for your excellent presentation and for your study. Congratulations once again. I think it's time to present our role model, Professor Valerie. She's a nephrologist with training in South Africa and USA, and she holds a master's degree in public health and PhD in biomedical ethics. She works in the Children's Hospital and holds an affiliate position at Harvard Medical School and the University of Cape Town. She chairs the ISN Advocacy Working Group Ethics Committee of the European Renal Association. Her research, we're talking about advocacy today, address justice, equity, and moral distress in kidney disease management, particularly in low resource setting in sub-Saharan Africa. She has highlighted disparities, access to dialysis and transplantation, and she's a strong advocate for equity, diversity, inclusion, and beside that, she's a role model for every one of us, and we all owe her a lot. Professor Valerie, would you please comment and analyze the study and work published by George and his team?
So thank you very much, Rasha. And a little bit exaggerated. I spend my time learning from all of you, and the only thing I can really do is try to amplify sometimes the voices. But otherwise, thank you so much for the privilege, because I actually get the list of papers from BMC Nephrology, and I was extremely interested when I saw this one. I have to say, even in the title, the word social reinsertion, I found very interesting, because I didn't really realize that that was sort of a technical term in a way. And I kind of felt that's actually really what we need to try to do in dialysis. So I thought that was already excellent, the title. I'm going to go just systematically through the paper as if I was reviewing it. So obviously everybody knows this paper's been reviewed. It's been published in a high, very well-regarded journal. There are no rights and wrongs necessarily. And I think, one can always find something else to comment. I'm sure even, George maybe has things that he's thinking sometimes, yeah, I should have said that, or I should have said that. So we all do that. One of the problems is we often stuck with the 3,000 words or whatever. We have so much we want to say, and we kind of limit it by word count. But basically for me, I think just starting with the abstract, I thought the abstract was very clear. It's obviously helpful when the journal gives you, headings like methods and results and all of that. But basically from reading the abstract, I was able to understand everything about this paper. So that's also very, very useful, because then that, first of all, if I'm rushing, gives me the information. And then second of all, makes me curious to read the rest of the paper. I think if we go into the introduction, and George, I'll just ask you to keep your slides up because we might refer to one or two tables, because a few things have just come into my mind as you presented. So I'll ask you maybe to go to some of the tables. But basically in the introduction, I think what's nice is that basically you put, the reason. So you explained the problem, you explained the huge lack of data, and you sort of put this a little bit in perspective of sort of the global situation. So I think that's extremely important. I think just one thing that you mentioned was that hemodialysis is a palliative treatment in your introduction. Hopefully it shouldn't be a palliative treatment, right? I think that's what it is, unfortunately, a lot of the time, because obviously it's only replacing 20-25% of kidney function at best. But I think your entire paper is here saying we shouldn't be accepting this kind of statement, right? We'd want to have people feeling good again. In terms of the methods, I think they were also very clear. I could understand the study design. I think you got your ethics. I think you got people to sign consent, which was obviously extremely important. You mentioned that it's in the government's funded centers, and you mentioned as well in the paper that basically most people can't afford private. So I think that's reasonable. This sounds like relatively generalizable to your, your general dialysis population, which I think is always important when one's reading a study, is to try to understand, is this just representing one place or is it representing multiple? And I think the fact you used 4 units and you had one that was 3, I think, were very big urban centers, and the one was a slightly less. So you also got sort of slightly different, probably, papers. You mentioned that you explained everything in the patient's language, which I think is great. That I didn't quite understand in the methods was how you administered the survey. Was that in the patient's language or not? So initially I didn't understand that. Then I went to the method, to your results, and in your results you mentioned that somebody sat there and actually administered the survey. So I'm guessing whoever it was doing it in the language. Was that correct, or was it all done in English or French? Do you want to?
No, yes. We got the questionnaire in the 2 languages. In Cameroon, we have 2 languages. We have the French and English. So we got the 2 language and the 2 language, and we have a local language called Pidgin English, which is a derivative from French, English. And so when the patient was not able to get what we say in French or English, we had to translate it in the language that was more easy for him to understand.
So okay, so that's
that was
sorry, no, I'm saying
that was our main challenge.
Yeah, so that's great. And I think if one has enough space in the methods, it's often good to say that, so that the reviewer will understand, that the patient probably, hopefully, really did understand the questions, and that the answers hopefully were also understood. And the patient could express themselves, I guess, also in a language, that they were comfortable with, which is probably important in this type of study. I think one question, and I might have missed it, was, did you validate your questionnaires? Because you used a very, a questionnaire that everybody uses, but I don't know if anyone has really validated it in Cameroon. And then you developed your own second sort of questionnaire, and did you sort of pilot tested and validated and all of that?
For the dialysis quality of life, we use what is available. We don't have been used to other population of dialysis, even though similar to us. We saw studies from South Africa, we saw studies from Nigeria that they use that. So we use the fact that it was used to the similar population to validate that. Now, to evaluate the social insertion, since it's something that was really difficult to bring it in one word. That's why you see the social reinsertion. We could not bring all that. So we made a questionnaire on our own. We defined what we see being good or not, like dropping from school. We said it was not good. So we defined our questionnaire and we made it that way. Okay. So we did not see a similar questionnaire somewhere where we could copy or adapt. So this one was locally made to evaluate the social reinsertion.
Okay. No, so that's good. I mean, I'm just saying that sometimes when, reviewers do ask you to explain, are you sure that the surveys are reliable in your community? I believe you. I think as well that, this SF35 or whatever it is probably, it's been done in so many different countries. And then your social insertion was relatively simple questions. So probably very likely the patients understood. The other question was, you decided this 50 as a cutoff. Is that something that others have used as well?
But the questionnaire, but when we had the questionnaire, we had to pre-text it. We selected a group of patients and we went and administer the questionnaire and see where we could have difficulty in, and then we had to work with the main investigator on that and the investigating team, so that they can overcome challenges when they meet a challenge with a patient who doesn't understand what we are talking about. Yes, how to overcome those challenges.
Okay, so that's good, but you sort of defined quality of life as poor, below a score of 50. So how did you choose that level of 50?
The level of 50 we chose was from other related studies.
Okay.
Related studies that had already put that ratio of 50, less than 50, more than 50. So we just have, and the references, I think the article.
Yeah, so that one sentence doesn't have a reference, but I think exactly. So I think that's perfect.
Okay.
So, just for the future, just for anybody, it's so great. If someone else has done something and decided that a certain level, then perfect. You just quote them, and then the reviewer won't come back to you and say, how did you choose, 50 instead of 45 or 55 or whatever. So that's excellent. Then, yeah, the one thing, and I think you definitely mentioned that as a limitation, was the idea that in some patients, you actually sat there during dialysis, right? And asked the questions. Yeah. So do you think everybody was totally comfortable with that? I mean, you mentioned that yourself as a limitation.
Yeah, it's clear that everybody will not give you I mean, sometimes the answers, they give answer to please you, or maybe if they have something to hide, they will not give you. So that's a limitation we had for the study, and it's a clear limitation when you do this type of reporting. The reporting bias is always present.
No, and I'm sure, I mean, it's probably too much time to take somebody in a room before or after dialysis. I guess they're all rushing and all of that. So, I think your results you've sort of explained. You started by showing your presentation, the European thing of people before and after starting dialysis. I'm just thinking, if you're going to do this again, whether or not you should try to have a sort of a control group, and just what do you, which groups do you think would be good as control groups?
Yeah.
Well, I can just suggest what I was thinking. Yeah, go ahead.
If we need to have a control group,
well, how would you know it's
be
different?
Difficult, because what?
How would you know it changed?
Because maybe I should explain actually what made us to go and evaluate, because we said all these patients, they receive the same dose of dialysis. All these patients, they face the same challenges when they come to the hospital, or our government or our public hospital. And we know that some difficulties that they have in public hospital, these people, they may have the same distance home to the hospital. That's why we wanted to do in town and somehow in some remote place, so that all these difficulties, all the patients that we meet have the difficulties. So that will not influence much in their quality of life. It may influence, but since it's in the same pool, it will not influence the statistics. So that's the reason why we took all the patients and analyzed it. Now, if we had to do a control group, we'll be doing control according to maybe some parameters that we choose. Maybe the quality of the dialysis. Maybe we should do something like that. Because actually we have some patients that have the 3 weekly session of dialysis. We can go among those and we compare with others. We compare with others. We may compare people in the rural area and those in the urban area. Maybe we may come out with some other results if we had to do a control group. So those are little ideas that I have if it happens that we need to come out with control group. I don't know if you had some, I mean, what are your ideas?
Yeah, no, I think you're exactly correct. And I think part of that could be done in a stratified analysis. So if you do it again, as a lot of people mentioned, looking at KT/V is obviously a questionable marker. I think people are not measuring it anymore, but I think hemoglobin, albumin, or whatever. And I think age is very interesting because you obviously have such young patients. And I think that's the message. You can't really compare your population to old people sitting in Europe or America. A huge amount of them are unemployed also because they're old, So I think the huge message for you would be really to stratify maybe even more closely amongst the age and maybe even, gender and whatever, because I think it's really interesting. And I think so you have all your patients and you just look, does hemoglobin associate with quality of life? Does albumin does, and then age, you could maybe divide into age, 10s or something like that. The thing as well that I find very interesting in your study is that most patients were actually dialyzing a lot of them were actually dialyzing for more than 5 years, not most of them, but maybe 1/3 or 1/4. So that's really amazing. It just shows that you guys are obviously delivering some level of quality if these people are surviving, So, I mean, I think it's such a different population of patients in Africa that this is exactly why we need these kind of studies. Also because, you can show that maybe it doesn't take as much to fight for quality of life in these people. Because I realized myself when I was in Johannesburg, just going with a hemoglobin from like 7 until 9 made a huge difference, when we were able to start giving EPO, for example. So I think, you guys definitely can maybe show that there are simple ways to change this. And then I think what I found also interesting, and this was maybe table 2, I don't know if you have table 2 there, but it's just interesting that the symptoms didn't really correlate, right, with quality of life, which I found fascinating, the physical symptoms. So I think you kind of showed, and others have shown as well, that somehow patients get used to the physical things, but it's more these other social things, right, that are impacting so much. And there I 100% agree with you. We need to figure out other ways to try to deal with this, because I think you had the symptoms greater than 50, where most patients had the score of greater than 50 with symptoms. So I'm not sure if you're able to show that table, but otherwise
I'm trying to get to the table.
Yeah, sorry, I should have written down the number of your slide. But otherwise, another thing, just while you're looking for it, I think here you mentioned your strengths, which are huge in the study, and it's not written in the paper. So I think one of the big things that I like to do when I write a paper is I always write strengths and I write the limitations, because the limitations, you're trying to put all the possible limitations so that the reviewer can't come back and criticize. So I think you did very well with the limitations, but I think you should also blow up your chest a tiny bit and just say, we have these very big strengths. This is a huge study. And, you found extremely important pieces of information. So, that was my only last thing, was really just this thing that you should be a bit more confident about your strengths.
Thank you.
I'm not sure if you found the table there, table 2, but I think it was the one with the subscales.
Yes, I'm trying to share the slides. I think the moderator should help me with that. It's not.
Yeah, anyway, it's not that serious, but I think it's just kind of interesting that in that table, it looked like, when you had symptoms and problem list, most patients had a score above 50. So I find that interesting, that the patients sort of get used to the physical things. So ultimately, I mean, I think it's great. I think it's great to get this out there where it's going to be seen by, the general kidney world. And I totally agree with you when you said we need data for advocacy. So I think this kind of information is also very important to go to the policymakers and just say, if you do find, the 3 versus 2 times a week makes a difference, it's a hard thing to ask for more money, obviously, but, at least in certain patients, maybe it's important. And the other question would be, if you wanted to really understand, is there a big change? You could enroll people in the first 3 months versus the chronic patients and see, show yourselves as well that you probably are improving their quality of life at that time.
Okay, thank you. Thank you.
So ultimately, I thought it was really good, very interesting and extremely important paper. And hopefully, now, as mentioned, you've got changes, you've got universal health coverage, you've got lots of things. So it'll be wonderful to see, if you can follow this up and maybe correlate a little bit with some physical parameters that might give you an idea of the quality of the dialysis, because then I think that's excellent. So thank you. It was really very interesting paper.
Thank you.
Are there more questions now?
Russia.
There's one more
I
question.
think there is only one question regarding if you have women, pregnant women on dialysis in Cameroon.
Yes, we have had some experience of pregnant ladies, pregnant women on dialysis, and we have had, if we can count, I think a total of 3 or 4 babies that we have had on hemodialysis, and most of the time we know it ends with premature delivery or abortion. So we have had some cases. We have had some cases.
In your center?
In my center, we have had 3.
Yeah.
We have had 3. We have had 3 pregnant ladies, or pre-confirmed, because there are some that may not even know that they were pregnant before the abortion occurred. So we have had 3 confirmed, but unfortunately, none have reached the delivery time.
I think we this is the last question we had.
One more.
Yeah. So is how do you win without micromanagement? Is it? How do we win without micromanagement? Yeah.
Micromanagement? I don't understand really.
I'm not getting it so well.
I'm not getting the question. Micromanagement. Maybe Valerie can help us. I don't understand the question.
So Amar, can further explain your question, please? Till we have further explanation, there is a comment from Sinada. She's appreciating the approach that has been used by Professor Valerian, seeking clarities and making recommendations to presenter. Thank you. We're really taking pieces home. Yeah, we are. I think we all agree on this. James Tao again, Denise, another idea to encourage policymakers could be prospectively assess how health coverage impacts these patients' outcomes.
Thank you.
Agree.
Thank you.
We had received the further explanation from Amar, who is personalized patient care for micromanagement.
Oh, personalized.
Patient care, yeah.
Personalized patient care. Yeah, I think definitely in patient on hemodialysis, we need a personalized patient care. There are decisions we take, but when the patient comes as individual. They have individual problems that we need to attend to. We may define the quality of dialysis in general. We may define other values for the general population of dialysis, but individually, they have problems that need to be solved, and the solution is never the same for a patient Y or another patient. So I think he's totally right, and especially when it comes to psychological support and other element of quality of life. I think the micromanagement is the key.
Can I ask one quick question? Stigma is obviously one of the problems. How does one deal with that?
That's very difficult to answer, because most of the time we even need to identify at what level in the society or even in the hospital the stigma is, because those patients, they are all, when you discuss with patients, they all tell you in school, maybe the administration, they are isolated. People don't want to play with them in school. People don't want to come in contact with them. So I think the first thing to do is to work on the patient itself. The patient himself you should work on the psychological aspect of that with the patient before you go into the community. If the patient accepts the situation, accept that other people may not see him or he or she as somebody normal in quote, then I think that's the beginning to the solution. So the psychological support should be integrated in the management of dialysis patients. In fact, in the management of all chronically ill patients, that should be something that should be integrated.
Yeah. So there is a comment regarding stigma as well, and ratio to inconvenience is a lot less as compared to vice versa. In African survival, instinct is unopposed to stigma. So I already agree.
I can't comment so much, but I think one thing that's interesting, the WHO has developed, and I think has worked with researchers, that there's sort of psychological support that people can get remotely. I think some of this was developed, for emergency situations, for migrants and refugees in different places. I'm wondering, if one could actually access some sort of support, or maybe this needs to be a project that somebody in the kidney community starts to develop a remote, patient support app or something, that one could help patients without having a psychologist at the bedside, that then they could see privately, maybe on an iPad or something. I wonder, it might be a project to think about if one could develop such a thing, maybe together with some NGO that might already have developed it, like MSF or one of the others. And one could have tried to adapt it with the patients for dialysis, maybe.
I wonder too, George, to what extent the cultural context affected the quality of life in the Cameroonian patients.
The context.
Cultural context, yeah, culture.
The cultural context. So yeah, maybe it was not. We did not take in consideration that, but where the various centers where we conducted the study, centers that we have some mixed up of cultures, so we don't have a specific ethnic group going for X or Y center. That's one. And when we talk about religion or that the Cameroonian society is so mixed that it's sometimes difficult to identify a specific culture that can influence this. So you go to the north, you see people from south, you go to south, you see people from the east, and then they live and then they adopt the culture of the place where they live. And at the end of the day, they are just like the people of that region. So that aspect, we did not consider it in the study because we thought that maybe he will not bring out something interesting.
Yeah. There's a question from Senda as well. I think Valerie have already commented on it regarding the conduction of a study exploring depression amongst patients as a follow-up. So great idea, I think. So I think as well there is a comment from Cinda Professor Valerie regarding this proposal or idea. She wrote a proposal earlier to the point, psychological support group for patients on end-stage kidney disease. So seems interesting and it's a great idea. There is a comment from Amar again. Less than 40% of Sub-Saharan have access to smartphones. Even lesser have access to internet. So he believed that we're behind on a lot of more than we comprehend. We lose a lot more to kidney disease than we communicate disease due to disinformation, lack of knowledge, and so. Professor Valerie, would you like to comment on this?
Sorry, I was answering a question.
Yeah, the same question, I think.
The one about that people don't have access to smartphones. Yeah, I know. I was just wondering if there could be like some sort of a tablet, in the unit, and a patient could use it while they're sitting on the machine, maybe. And different patients obviously get to use it on different days. I don't know. I think there might be, one would have to find ways around it, but yeah, obviously there's local barriers, and I think the local teams would have to try to figure out what might be useful. I'm not sure how, I think one needs I'm just thinking aloud. I think one would need to investigate what's in the space already, that one might be able to adapt. But you're right. Obviously, people would need access to be able to get onto these websites or apps or something.
Yes, what do you think of this, George, based on the available resources?
If we have to develop such an app, normally the percentage of population on dialysis who have access to internet, who have access to smartphone, we need to study that to see how effective we can be if we introduce such approach in the management of their psychological issue. But I think for the meantime, we should go for the physical approach. That is getting somebody that comes closer to the patient and discuss his psychological issues, and then gradually with the difficulties, with with the results of that, we can think of developing the remote consultation. So sometimes when it's remote, we know our population, they may not accept it that fast. Even those who have the facilities, even those who can get access to internet, who can get access to smartphone, who can get access to a computer, they may not, but they like the physical approach. don't forget that we are in Africa. We like the physical approach of things. So that's my opinion on the
And I think this largely depends on the level of education of the patient, use the smartphones and the social media network. And so it also considers the level of education of the patients. I think we have addressed all the points or comments, maybe. I think that's it. So I'd like to thank you again, George, for your work. Congratulations to you and your team once again. Thank you for your presentation. And I thank you so much, Professor Valerie, for the insightful discussion and very informative comments. Thank you so much, everyone, for attending this webinar. And I'd like to remind you again that Share Your Article is a series of webinars that introduced by the Young Nephrologist Committee, and it's again inclusive for everyone. So if you have your articles published, please share your articles with us via email, and we'll be happy to be our presenters in the next meeting. Thanks so much for everyone. Looking forward. Thank you.